Welcome everyone to our Lunch, Learn, Link seminar for the first one in November. And this is a seminar co-sponsored by the Sidney Kimmel Comprehensive Cancer Center and supported by the Cancer Prevention and Control Program, and supported in large part by the Cigarette Restitution Fund. So we want to acknowledge that. Today is a real opportunity to have you hear from the state of Maryland, the Department of Health and Mental Hygiene, about one of my favorite topics, and that's cancer control in Maryland. I'll just say that back in 1990, when I was at the State Health Department, Maryland, in terms of cancer mortality, was first among the states, that is worst among the states, and today we're about 30th among the states, depending on what year you look at. So we have made progress. And Meredith Truss is program manager at DHMH in the Maryland Prevention and Control Office, and she will bring us an overview of the Maryland Cancer Plan. There's been 5 of them now, and each one has its own character and its drive for the future. And I invited specially today the Anna Bacher Society, so you'll see a number of students who are intending to go into public health. They will man the microphones and help us with the questions and answers. But I wanted to start out by having Josh Sharfstein say just a word about what a cancer plan, what a health plan means for a public health official. So a number of years ago now, he was health secretary in Maryland and actually oversaw a good bit of the activity around the Cigarette Restitution Fund and the creation of cancer plans. So I've asked Josh to come up now.
Great. Thank you. Hi, everybody. I'm Josh Sharfstein. I'm Associate Dean for Public Health Practice and Training. Thank you, Norma. Norma does, actually just telling me all the different things that she does here, but one of them is to oversee a whole bunch of research grants that are possible because of cigarette taxes, grants that are related to cancer prevention and control. So I was the health secretary in Maryland for 4 years, and got a chance to see up close cancer planning. You know, what is the role of public health in when it intersects with medical diagnoses? You know, it really depends a bit on the medical diagnosis. There's certain things that public health is deeply into, and there are certain medical diagnoses that public health has almost nothing to do with at all. And cancer is one where public health has something to do with it, and we're probably just scratching the surface of what is possible. The biggest issue for public health generally is prevention. There's just such a huge amount of prevention in cancer. And the history of Maryland is really interesting because, as Norma said, Maryland was doing very, very badly in preventing cancer. And it was quite embarrassing. There's just no excuse for a state with the kind of income that Maryland has, one of the richest states in the country, to be the worst state for cancer incidence. And part that reflects the fact that we have a very active clinical, people can get clinical care in Maryland for cancer, but at the time we really had very little on the prevention side. And that appreciation led to a lot of activities well before I became secretary, including the formation of a coalition, the development of a plan. I actually think the process of developing a plan is almost as important as the plan itself because it gets people really active and engaged in what needs to happen. There was a huge amount of advocacy. It's how the cigarette tax got put into place and a huge amount of money designated for cancer that funds not just the research but also screening and public health prevention programs that dramatically increase the amount of screening that happened in the state. And you can really chart a decline in some of the key measures in Maryland to the investments that were made, not just in the key measures, but in disparities associated with the key measures. I'll tell you one story just to try to dramatize the role of having a cancer plan and a cancer group, which was had to do with tanning salons in Maryland. I don't know if you remember this, Meredith, but so we have tanning causes cancer, and just because of the ultraviolet light, and we had a consent form for tanning for minors that said basically everything in moderation. I'm paraphrasing. It wasn't exactly clear on the issue, and some oncologists raised with us the concern that maybe the consent form for tanning wasn't accurate. Now, there have been many attempts to just ban tanning for kids in Maryland. Texas bans tanning for kids. Maryland didn't. I don't think it does even now. But nonetheless, the General Assembly didn't approve that. But the consent form was up to the state health department. So we did an advisory committee and we looked at the evidence and we basically came up with a consent form that said, looks like this causes cancer, and all these different groups say that it causes cancer and you shouldn't do it. So it's pretty much more aggressive. It went from a kind of everything in moderation to like, don't do it, this causes cancer kind of consent form, to make sure people really understood if their kids were going to do this, that was a problem. And we also put time limits on the consent. We did a bunch of things to try to strengthen the consent process. Well, there was an enormous pushback from the tanning salon world. I got letters from at least 20 to 30 members of the Maryland General Assembly, including some of our appropriations chairs and others, saying, there's not a scintilla of evidence, Dr. Sharfstein, that tanning might cause cancer. It's all a myth. It's totally ridiculous that the state would even consider that. And there are people at the state health department quite concerned. We had some very powerful legislators taking the side of tanning salons on the science. What do you do? Well, we had the choices. We could back off. We could just plunge forward and risk whatever happened. And the choice that I picked was to convene the planning, the cancer advisory group that is part of the planning process, that exists in Maryland for the purpose of cancer planning and is chaired by the heads of the 2 cancer centers in Baltimore, to answer the question. And so I called the members of the General Assembly back and I said, I got your letter, I appreciate it, and I understand you have concerns about our science, so we're taking it to the committee that is chaired by the head cancer oncologist at Hopkins and the head cancer oncologist at Maryland. And because we had this relationship and this plan, we did that. They voted unanimously for a very strong consent form. Essentially, maybe they changed one word of our proposed form. But it was not, they certainly found that it is a carcinogen. And, we moved forward with the new consent form. And, it basically provided a basis for more rational policymaking in this area. And so to me, the process of this, just having a plan isn't necessarily good enough, but the process and the fact that there are people who worked on the plan, who are going to fight for aspects of the plan, who are going to, go there, get the cigarette tax, designate the money, be there when the health secretary needs you on a particular cancer issue. Those things are really important too. I think that cancer is just such a difficult challenge, and yet at the same time, and cuts across, and as the plan does, prevention, care, and hospice and palliative care, that it's just great that there's a team at the health department that's working on that. And I think that what Maryland has shown is you can accomplish a lot with a public health orientation, but I would probably also say that a lot more can be accomplished with a public health orientation in each of those areas. And I think each plan is really just the starting point for that discussion in any state. But I think it's been done pretty well, and I've been very impressed with the team that works on it. And with that, maybe I'll turn things over. Back to you, Norma. Okay, well, it's my pleasure to introduce then Meredith Truss, who has been at the State Health Department 9 years. Is that right? Yes. You told me? Excellent. To present the cancer control plan. Thank you.
Hello, everyone. Thank you so much for coming out today. I did want to start by letting you know that I believe that we have copies of the cancer plan available at the table at the back for anyone who's interested in picking one up. It is also available online. So with that being said, I am Meredith Truss, and I'm the Comprehensive Cancer Control Program Manager at the department, and our program oversees the development of the cancer plan as well as implementation of the cancer plan through a statewide coalition, which I will talk about later. So I'm going to start out with a little bit of context about the cancer plan. The CDC funds comprehensive cancer control efforts throughout the United States. All 50 states and most of the tribal organizations, and territories are funded to develop and implement cancer plans. And we have had one in Maryland in some form or another since 1991. So we have quite a history of cancer planning in Maryland. The cancer plan is a guide for any professional who is involved in planning, directing, implementing, evaluating, or researching cancer control. It does include goals, objectives, and strategies that guide cancer control, and they are for a 5-year period. It's also intended as a resource for Marylanders, including professionals and the public, on cancer topics. The cancer plan is intended to prioritize needs as well as foster collaboration and streamline initiatives so that we can maximize impact. And that's sort of the whole purpose of comprehensive cancer control efforts, just in general in Maryland and in the United States and other states as well. It's really prioritizing and collaborating. So the plan is not just a plan for the department, although it is developed by the department. It's meant for anyone in the state of Maryland who's interested or involved in cancer control. So this image here is what our last cancer plan looked like that we released back in 2011. A little bit more context on the cancer plan. As I mentioned, it's intended for use by all of our partners. DHMH does lead updates and publication of the cancer plan, so final determinations on the content in the cancer plan are made by the department. However, we depend on all of our partners to help us by providing feedback and implementing the cancer plan. And so getting the endorsement and involvement of our partners from the beginning when we start the process of updating this every 5 years is very important. And during the most recent update for our current cancer plan, we had more than 80 partners who were involved in providing feedback during the process. So I'm going to go through a little bit of the timeline of development of the cancer plan. We started the update for this cancer plan, which was just released in September, back in 2014. So this was a 2-year process. It does take a long time because involving our partners who are volunteers, it's a lengthy process. So we started by looking at our last cancer plan, which was huge. It was a binder. It was massive. I think we had 15 chapters, and we had over 200 people who participated in that process. When we looked at the cancer plan, we also decided that it would probably be valuable to work with some experts at the CDC level in comprehensive cancer planning, and they gave us some recommendations based on national trends in cancer planning. So we made a few decisions about changes that we were going to make this time with the cancer plan. The first plan is that we decided to streamline the content of the plan. So the current cancer plan is much shorter than the last cancer plan. We focus on cross-cutting content as well as objectives and strategies, and we decided to cut back on some of the data included in the cancer plan. The last cancer plan included, I think, 5 or 6 site-specific chapters, and each one of those included lots of background data, and because of the length of time that it takes to update these plans, the data is outdated by the time it's published. So we decided it didn't make sense. Those updates were already published elsewhere, so we took out a lot of the background data. And again, we focus on the cross-cutting content this time instead of site-specific chapters and objectives. Focusing on goals, objectives, and strategies versus that background information. And we also decided to streamline the process. So in the past, well, I'll come back to that in a minute, but in the past we really asked a lot more of our stakeholders and volunteers, and this time we decided that instead of asking our volunteers to actually write the plan, that DHMH could take on the responsibility of writing the plan and then bring our partners in to provide us feedback to reduce the burden on them. So in the winter 2014 to early 2015, we did go ahead and draft the cancer plan. Once we had our draft ready, in May and June, we collected partner feedback through various meetings that we held. And we took all of that feedback, worked it into the draft, revised it, and presented it again to our partners to make sure that everyone was happy with the final product. July, August, September, we finished incorporating all of that feedback, reviewed our data one more time, and in the fall, late fall, we started the graphic design. We finalized the draft and started the graphic design phase. January through May, we continued working on graphic design and editing. In May, June, we printed it, and at that point, by the end of June, we had all of these cancer plans, but we weren't really sure at that time how we were going to release it. We knew that we wanted to do something to celebrate the release and get it out into the public. So we decided to hold off a little bit, and ultimately we were able to have Governor Hogan become involved, and he released the cancer plan for us in September during a press conference to celebrate the release of the cancer plan, as well as an update to our state advisory council on cancer control. So that was very exciting for us. So I'm going to go back to that May and June 2015 period when we brought our stakeholders in to help us to give us feedback and finalize the cancer plan. So I spoke a little bit with Norma and Elizabeth in advance, and they thought that it would be really interesting for you all to know how the stakeholders are involved in finalizing this cancer plan. So as I mentioned before, during past updates, we relied heavily on our volunteers to actually write the cancer plan. But I mentioned we had 15 committees, and each committee, 15 chapters, each chapter had a committee. And so these committees met at least 5 or 6 times each, and it was a huge time commitment for all of these volunteers. And we decided this time that after we consulted with our national contacts that it would be easier and faster for us to go ahead and draft it ourselves and utilize our stakeholders and experts for feedback on what needed to be changed. So we went ahead and drafted it. We gave it to them, to our partners, to provide feedback to us. We held several meetings and invited anyone who was interested to come and participate. We actually had templates that the consultants provided for us. They were very specific to give us feedback for suggested revisions, content that was missing, our objectives and our targets. And we used several facilitators to break down our partners into small groups to review the feedback and their suggestions and come to a consensus on what this group that participated in this process wanted to present to DHMH to incorporate into the draft that we'd prepared. So this was held over the course of, I think, 3 meetings in May. We took all of that feedback and then we incorporated it. I think we incorporated almost all of the suggestions that we received from those meetings. We revised it, and then we held a final meeting with our stakeholders again to show them how we had incorporated what they suggested, and eventually finalized it after a couple of minor suggestions after that last meeting over the summer. So this whole feedback process and stakeholder involvement process is really important for comprehensive cancer control because we depend on you all, our partners, to actually implement the plan. So having buy-in on what's included is so important for us from the very beginning. Okay, so I'm going to talk just a little bit about what's included in the cancer plan over the next few slides. And I'm not going to go into a whole lot of detail about the actual targets because I have copies of the cancer plan here, and it's still very large, even though it's shorter than the last one. So there's a lot of content, so feel free to, if you have questions specifically afterward, let me know. So our objectives, just generally speaking, the way that we identified our objectives, first we looked at the last cancer plan. And we looked at objectives that had been achieved, objectives that were we still needed to work on, and objectives for which we had data. Because in the last cancer plan, many of the objectives were actually not based on specific data, and this time that was a goal of ours. So I believe all of the objectives except for 2 or 3 in the cancer plan are based on available data. We also looked at objectives that were similar or repetitive throughout the cancer plan and consolidated those. We drafted our objectives in consultation with our internal DHMH subject matter experts, as well as some of our external partners, and we based them on areas of significant need or burden in Maryland. So I mentioned that our goals for these objectives are that they were SMART, so that stands for specific, measurable, attainable, relevant, and time-bound. And we wanted to make sure that they were really data-driven. Also cross-cutting versus site-specific. So in the past cancer plan, we had, I think, 5 or 6 different cancer sites, each with its own set of objectives. This time we combined all of those into one objective for cancer incidence and one for mortality, with multiple targets underneath of that one objective, because most of the strategies for achieving that were repetitive anyway. So the data sources that we use for our targets throughout the cancer plan, these are some really great sources of cancer data. They're available, most of them online through the NCI. So we used our internal cancer registry data for incidence. We used CDC Wonder mortality data. We used Behavioral Risk Factor Surveillance System, BRFSS, and Youth Tobacco Risk Behavior Survey data, YTRBS, for behavior and risk factor objectives. There are a few that include data from the National Immunization Survey, and then there are a couple of other sources here and there throughout, but these are our primary data sources for our targets. We have targets for all of our objectives for the year 2020. And so the way that we set these targets, so for our behavioral and risk factor targets, we started out by looking at Healthy People 2020. And so if the Healthy People's 2020 objective had not yet been met in Maryland, we went with that objective, unless the Healthy People 2020 objective differs from other goals or objectives that are set by DHMH programs. So in some cases, some of our well-funded programs at the department, like the tobacco program, may have slightly different objectives for tobacco use, and in some cases they are more, in some cases they're less aggressive, but we thought it would make more sense to go with those in lieu of the Healthy People 2020 data, because they're probably a little bit more achievable, realistic in Maryland. In cases where we had either already met the Healthy People 2020 objectives, or if one did not exist for a particular objective we wanted to include, then we used the HP 2020 target setting method, which adjusts the baseline by 10%. For our incidence and mortality targets, we use linear forecasting. So we looked at 10 years worth of Maryland data and projected for 2020. And in cases where the trend was going in the right direction, we went with the 5-year trend for 2020 as our target. Okay, let's see. Oh, and also, as I mentioned, in Section 2, Section 2 is our high burning cancer section of the cancer plan, and I'll go through our table of contents in a minute. But we have one objective for incidence, one for mortality, and under each one of those we have targets for multiple cancers. For our strategies in the cancer plan, each objective has a set of strategies related to it, which is how we think that we can implement or achieve that target for the year 2020. So when we developed our strategies for this cancer plan, we looked, again, starting at the last version of the cancer plan, at strategies that still made sense, that hadn't been implemented yet. We consulted with subject matter experts again. We relied heavily on sources like the Community Guide and the United States Preventive Services Task Force recommendations throughout. And we also focused on cross-cutting versus site-specific strategies for our strategies as well as for objectives. For strategies, we also focused on policy systems and environmental strategies. So PSE strategies are intended to reach populations versus individuals. So rather than, if we want to increase screening rates, rather than doing a public education campaign about cancer screening and educating people one-on-one, let's change the system. Let's change something in the healthcare setting that is going to impact all of those patients more directly. So we looked at those kinds of changes and focused on those strategies when possible as well. There are a few themes that are overarching throughout the cancer plan. We do address cancer disparities throughout in each section of the cancer plan. In the last version of the plan, we had a chapter that was specifically dedicated to cancer disparities. This time we thought that's something that impacts all areas of the cancer spectrum, so that needs to be addressed throughout the cancer plan, not just in one separate section. So it's throughout the cancer plan. We do take advantage of healthcare reform and opportunities, like the fact that now the USPSTF recommendations with an A or B strength are generally covered by health insurance, so we include those throughout. We focus on data whenever possible when we set our targets, and those policy systems and environmental change strategies. So this is the cover of the cancer plan. It's a little different from the last version, and I don't know if you can see this very well, but this is an outline of the table of contents. It's a little snapshot of the table of contents. So the cancer plan includes 3 sections. We have one section on primary prevention of cancer. We have a section on high burden cancers in Maryland and priority cancers, and that's where we address incidence, mortality, and screening. And then we have a section on survivorship, palliative care, and hospice care. And the last cancer plan, really a good part of the cancer plan was dedicated to site-specific cancers. This time we have a huge focus on primary prevention of cancer. And as Dr. Sharfstein was saying earlier, there are so many opportunities there for public health interventions. So we know now that so many cases of cancer can be prevented. So it was very important for us to stress primary prevention in this version of the cancer plan. You can see it's page 22 through 35. So it's a good section of our cancer plan now is focused on prevention. So this is just a little snapshot of the topics and objectives that are included in the cancer plan. There are only 4 goals in the cancer plan this time. In the last version, I think there were 25 to 35, somewhere in that range. So we've consolidated it down to 4 goals. We only have 23 objectives in this cancer plan. It's still a lot, but it's a lot less than the last time. And some of our objectives have multiple targets. So within primary prevention, we have 2 goals. The first goal is to increase cancer prevention behaviors in Maryland. And under that goal, we have, I think, 12 objectives, and those are related to tobacco use, nutrition, physical activity, healthy weight, breastfeeding, alcohol consumption, HPV vaccine, and ultraviolet radiation exposure. And our second goal is reducing cancer incidence by minimizing environmental exposures. And this is one goal. We have 2 objectives here. These are 2 of very few objectives in the cancer plan that are not based on data with measurable targets because we don't have access to that data yet. So developing those data sets is incorporated in these strategies for those objectives. Section 2 is high burden cancers, and our goal in high burden cancers is to reduce the burden of cancer in Maryland generally. And we have 4 objectives under Section 2, including reducing cancer plan incidence, mortality, increasing screening rates, and decreasing disparities in incidence and mortality. And so Section 3 is survivorship, hospice, palliative care, and hospice care. And our goal there is to increase the quality of life for cancer survivors. Our objectives are related to survivor, physical and mental health, whether their pain is under control, survivorship cancer survivorship plans, CAPC report card grade for palliative care, and cancer patient hospice utilization data. And that objective is actually one of our other objectives that is not based on data sources right now because that's another one that we don't have available statewide. So we do have an objective to begin collecting that data. So there was a suggestion before my presentation to maybe look at some of the priorities in the cancer plan and present priorities to you all. And I looked at that and I thought that when I look at the cancer plan as a whole, really everything is a priority in the cancer plan. That's why it's there. So DHMH we don't prioritize the objectives that are in the cancer plan for the entire state. They're in there because they are a priority. So there's really something in the cancer plan related to anyone who is working on cancer control in Maryland. Overall, obviously reducing the burden of cancer in Maryland, so reducing incidence and mortality are key, increasing screening rates as well, but primary prevention is huge. So anything that you are interested in related to cancer control, there is something in the plan that relates to what you're doing, so take a look. Okay, so this is a snapshot of what the goals, objectives, and strategies look like in relation to one another. So we have, for each section, we have this broad goal, which is very broad and general, and within that we break it down to multiple objectives, and this is an example that has several targets. This is for increasing HPV vaccination rates. And then related to those targets and that objective, we have strategies, which are the activities and how we actually think we are going to move forward with that objective. And I will say that HPV vaccination, the reason why I included this on here, so the department doesn't prioritize objectives from the cancer plan for the state, but as a department within our own administration, we have prioritized HPV vaccination for some of our internal efforts. So I have a few slides just to present examples of some of the data that's included in the cancer plan. This is a table that gives some of the current data, well, it's actually not current anymore, but at the time of publication, some of the data on HPV vaccination for girls and boys. this is one of our slides or one of our graphics from the high burden cancers section. And when I've done this presentation in the past, I usually get a question about how DHMH defines high burden or priority cancers. And so in section 2 of the cancer plan, we do provide some of this background data, and we generally present it in terms of the 10 cancers with the highest incidence and or mortality. And so this is kind of this is an interesting data set for men versus women of the leading sites for cancer incidence. We have a similar one for mortality. And then we also have this slide, which I actually really like this graphic. It shows a comparison of the cancers with the highest incidence and mortality, on either side of that. So it kind of shows you where there are a couple of disparities there with lung cancer in particular causing such a high burden as far as mortality goes. But it does show you that the top 4 cancers are the same, whether you're looking at incidence or mortality. Okay, so also in section 2, we have some data on cancer screening rates, just as a little bit of background. In section 2, I mentioned we present data on the 10 highest incidence mortality cancers. We do also further define a few cancers as particular priorities because they are targeted by the Cigarette Restitution Fund, and those are breast cancer, cervical cancer, colorectal cancer, oral cancer, prostate, melanoma, and lung cancer. So for those 7 cancers, we do include some additional information. Cancer screening rates for the 5 that have some sort of population-based recommendation. Lung cancer is not included on here right now only because we don't have that baseline data yet for lung cancer screening. But those 7 priority cancers are the ones that we set the targets for. So we provide information on the top 10, data on the top 10, but we set targets for those 7 which have been prioritized because they have a high burden in Maryland, but they also have modifiable risk factors and or effective screening tests. Okay, so the next part of the presentation sort of shifts from what's in the cancer plan to what do we do with the cancer plan. So the cancer plan, it's intended for use by everyone working in cancer. So what we always ask when we present this to our partners is to use it. So look at the cancer plan. There's something in there related to what you're doing. Look at the goals, objectives, and strategies and see how that relates to your work or your research, your studies, and incorporate those strategies into your work. Another way that we encourage implementation of the cancer plan is through the Maryland Cancer Collaborative, and I'll talk about that in my next slide. And then finally, we want to know what you're doing about the cancer plan. So we have a process set up that allows anyone who's working on cancer in Maryland to tell us what you're doing so that we can report that back to CDC. So the Maryland Cancer Collaborative. The Cancer Collaborative is a statewide coalition of volunteers who are charged specifically with implementing the cancer plan. CDC funds all of our comprehensive cancer control programs across the country to develop these cancer plans, and they also fund us to convene coalitions of stakeholders to work on implementing the cancer plan. So we have funding to develop the cancer plan. We have funding to convene a coalition. We don't have funding to give to the coalition, though. So getting back to what I mentioned toward the beginning, the whole intent of this is to collaborate and streamline efforts and maximize existing resources. So actually, Dr. Elizabeth Platts, who's here today, is the chair of the Maryland Cancer Collaborative. So Hopkins has been a really strong partner for us in implementation through the Cancer Collaborative and other efforts as well. So MCC members choose priorities from the cancer plan. They review it. We met back in April 2016 and looked at all of the strategies in this new cancer plan once we had finalized the content. And again, through a group consensus process, we chose priority strategies, 5 priority strategies to work on in 2017 and 2018. So we formed these priorities, chosen these priorities. The next step is to form work groups around these priorities, and that's how the Cancer Collaborative implements the cancer plan. So the new work groups, they were chosen back in April 2016. They are currently forming. So we're recruiting members to these new work groups. We have leaders identified, and they will be meeting over the next few months to develop specific action plans that they will then implement to support their priority objective. So I have the 5 priorities of the Cancer Collaborative up here. One is related to providing tobacco cessation in hospital settings. One is related to implementing system changes to encourage HPV vaccination. One is increasing access to care and resources to underserved populations. One is to start a process to collect hospice utilization data by cancer patient status. And finally, one related to communication to increase messages related to cancer to the general public. So, up at the top, I have our Facebook page, and I always like to give a plug for this because we include so much information and we update it regularly. So through our Facebook page, we post news, research, events, really anything that we come across related to cancer that we think our members may be interested in. And so if you have a smartphone, which probably everyone here does, if you have it with you right now, you can go ahead and like us. You don't have to like the page to view it, but go to the page, check it out. There's a lot of really great information. We get lots of good feedback. So even if you're not interested in joining the Cancer Collaborative, follow us on Facebook. If you are interested in joining, membership is open to anyone who is interested in working in cancer in Maryland. So we have, on the last slide, I have our website. So we have a Join Us form on our website. I also have some here today, also with the cancer plans for anyone who's interested in signing up now to work on one of these priorities. So I wanted to include a few examples of how both the Cancer Collaborative is implemented, strategies from the cancer plan, as well as how Hopkins here has implemented strategies from the cancer plan. I thought that might be interesting to see some inspiration. So one of our past Cancer Collaborative work groups was focused on palliative care. And what they wanted to do was survey hospitals in the state to get a baseline of what's available as far as palliative care services, what hospital initiatives were underway, what their barriers were, and needs, so that we could identify ways to improve access to palliative care and knowledge about palliative care. So our work group partnered with several other entities in the state and developed this survey that we administered to all of the hospitals in Maryland. We collected tons of data, and once we collected the data, we realized that we didn't really know what to do with it. So this is actually a really great example for any students here of how you can get involved. We worked with Elizabeth and Norma to identify a cancer prevention fellow here at Johns Hopkins who came on board with us, and as part of his, I believe it was his practicum project, he took that data from us and analyzed it and produced results that we could use. And he also actually drafted an article for us and submitted that, and was ultimately accepted to the Journal of Pain and Symptom Management. So there are so many projects that we have utilized interns for through the Cancer Collaborative. And I'm sure that either Elizabeth or Norma would be happy to work with you on identifying something from the cancer plan that interests you that you could use as a student project, particularly in the spring, I guess, once our work groups are getting underway, or just as an independent project. There's lots in the cancer plan that you could look at to identify something to meet one of your requirements. So this was a really great example of a collaborative effort between our work group through the Maryland Cancer Collaborative, our student help here at Hopkins, and also some other organizations that endorse the survey effort for us. So this is another example, and the next two are initiatives that were undertaken by Johns Hopkins without necessarily looking at the cancer plan and going through the strategies and picking something out that they wanted to implement as a new priority. This was done by Hopkins because it was an organization priority, but it still counts as implementation of the cancer plan, even though that wasn't necessarily what led to this policy. It still counts. So this is related to the tobacco-free campus initiative here at Johns Hopkins, and I copied and pasted this from a summary that we have about the program, but I highlight this because this particular project actually won an award from the Maryland Cancer Collaborative back in 2015. Every year, the Cancer Collaborative gives out Cancer Plan Implementation Awards, and this project won our award for Innovative Policy or Environmental Change in 2015. And the next one is another Hopkins example of the Managing Cancer at Work program. And so this is another example where they didn't necessarily look at our cancer plan and say, oh, there's something new that we want to incorporate. This was something that was the initiative came from within the organization, but again, it still counts as cancer plan implementation. And so they filled out one of our implementation report forms on our website, and this one won Innovative Systems Change Award from the Maryland Cancer Collaborative as well. So just generally speaking, the take-home point is that the cancer plan is comprehensive in nature. It covers everything. So whatever you're doing, there is something in the cancer plan that's related. Even if you aren't going into the cancer plan and picking something new, what you're already doing counts as implementation. And so we want to know about that because we report that back to CDC, our funder. We also publish an annual cancer plan progress report through the department. It's on our website, which I'll show you on the last slide. And in that progress report, we publish success stories of implementation of the cancer plan. The only way that we really know about those success stories is if you tell us. So to that end, we have our implementation reporting tool on our website. And so I mentioned that we have a couple of perks for people who submit those. So we do look at every reporting tool that we receive, and we consider them for publication in our annual cancer plan progress report. And in addition to those two examples that I just told you, I have a couple of other examples of success stories that we've published in our progress report up here. And then the Cancer Collaborative also gives out our annual awards. And so this year we are going to be giving out awards at the November 15th Cancer Conference, which is coming up. We just determined our awardees for this year. So we are excited, and the organizations that receive these awards are generally very excited to receive them as well, because it does get recognition out to a pretty broad audience about the work that they're doing. So that's the end of my presentation. So my contact information is not up here because my role at DHMH is going to be changing over the next few weeks. So I have contact information for Brian Mattingly, who's here today. He's over there. He's going to be a good contact going forward related to anything for the Cancer Collaborative, also Elizabeth and Norma, or the cancer plan, or how DHMH is implementing it. So I have his contact information up here. I have our website up here. I also have business cards with me, so if you have a specific question that you wanted to ask me, I'm happy to give you my contact information, but I thought Brian might be a more appropriate contact going forward. So that is all that I have. So thank you.
Testing. 1, 2. Yeah, I had a question about data. I'm not sure if you can answer it. Which of the cancers have shown the most improvement since the plan was implemented, and which have been seem to be particularly difficult to solve?
I would say that colorectal cancer is one of the cancers that has seen the biggest improvement over the decades in particular. In addition to that, I believe we've seen pretty big increases in at least breast cancer screening rates. So historically, I don't know, it depends on what time frame you're looking at, but so lung cancer is definitely one that still remains problematic for us. We are hoping that with the new recommendations for lung cancer screening, as that's sort of worked out over the next few years, that hopefully we will start to make an impact there. Obviously, tobacco prevention through tobacco cessation and prevention is important for us. Elizabeth, do you have any more thoughts about that?
Actually, talk more about colorectal cancer, because there was such a push by the state to make sure the uninsured had access to screening. That makes such a huge difference.
Yeah, so colorectal cancer is one where we've seen big improvements. And back when the cigarette restitution fund was settled and Maryland received all of this funding, part of that was the local health component. And so a lot of funding was dedicated to the local health departments, who were able to choose particular cancers that they wanted to target. And all of them, with the exception of I think one, determined that colorectal cancer was a huge burden and a priority. And so through the Cigarette Restitution Fund money, we were able to implement cancer screening programs across the state to increase access for uninsured and underinsured low-income Marylanders. And in addition to that, there have been a few other CDC initiatives that have supported population-based screening and also education about colorectal cancer screening and the importance of it. So between the CDC funding for the National Colorectal Cancer Control Program, which is population-based screening promotion, and our state level funding and determination of that as a priority through the Cigarette Restitution Fund, that is definitely an area where we've been able to make a lot of progress.
I have a quick question. How have your objectives changed from the previous plan to the current plan? Or have they changed at all? Or
Well, so more than just the previous plan to the current plan, but if you go back to those first two cancer plans back in the 90s, the objectives were focused, I think, solely on breast and cervical cancer. So we have expanded, and now we include objectives from everything from tobacco through HPV vaccination, screening, survivorship. So it's definitely evolved over time. Some of the biggest changes in the objectives this time actually are in the survivorship chapter, because we didn't really have any data-driven cancer survivorship objectives in the last plan. So we do have several new objectives in that section of this cancer plan focused on supporting cancer survivors. There are targets for the 7 priority cancers for incidence, mortality, screening, and disparities. And those are, so the reduction in incidence and mortality is repeated from the last cancer plan. The targets have just been changed a little bit. And so a lot of the objectives are kind of similar to what was in the last plan. We just updated the target. I think survivorship is the area where we really saw the most addition of new objectives.
We add on to that one, 'cause I think there's been also an evolution. So, for example, for tobacco cessation, in the past, the focus was more on individuals and educating individuals and making sure they have access. But now it's about PSE, so policy, systems, and environment change. So actually moving into health systems to make a difference. So that's a very different approach for many of the strategies. And then the other point that you already made was about smart. They have to be smart objectives, and the strategies have to then follow those objectives. In the past, we tried to encourage the development of strategies that were smart, but we weren't we didn't stick to our guns as much as we did this time, I would say.
I think we only allowed exceptions.
Sorry to use the word gun, because I actually don't like using the word gun. Sorry about that. So we stuck to our plan.
Yes.
Yeah.
I think all of the objectives are data-driven, with the exception of the few where there is not current data available.
And then we propose to.
Right. The plan is to start collecting that so that we can make them data-driven in the next version of the cancer plan.
Is anyone a member of the collaborative? How many are a member? It's easy. It's actually super easy. It's great to sign up. You're a member. Really?
The city cancer code.
Oh, look at the state too.
I got drafted.
Oh, you have an email, newsletter.
Yes.
Talk about that a little bit?
Yes, so in addition to the Facebook page, we have a monthly, we call it our e-update that we send to all of our coalition members. So the Facebook page is open to anyone. You don't have to be a member to look at the Facebook page. The e-update is just sent to members, and it's sort of a perk. We use it to, it's like if you join, you're going to get this email. And it is very helpful. So it includes a lot more than what's just on the Facebook page in terms of events that are coming up. We include volunteer opportunities. We post job announcements from all of our partner organizations or member organizations, lots of cancer news and data, resources and tools that become available from CDC, continuing education opportunities as we receive them. So we send that out once a month, and that's an initiative that we implemented a few years ago, and it's probably our most popular initiative based on our member satisfaction surveys. So it's a perk for anyone who wants to join.
I have another question. How many of you knew that we had a state cancer plan? Josh knows. Anybody else? Brian knows. Anybody else? All right, Paul knows. Students who happen to be in our group know. No one else knew there was a state cancer plan. And we've had a state cancer plan since 1991. there's sort of social media, web pages, hard copies. So so when I talk to people around the state, and I bring this up, no one seems to know. So Josh, I'm sorry for jumping right there. Any sense of how we can actually increase recognition by residents in the state of Maryland that there is a plan? There's not a haphazard process. We have a state plan.
I don't know if I would put that at the top of my list of what I want people in Maryland to
Okay.
be thinking about.
Okay.
You know, I mean, I would want people to know not to smoke and that there's,
Right.
you know, resources to quit smoking before that there's an organized cancer plan.
All right,
process.
that's fair.
So, you know, I think that the right thing to be measuring would be the kinds of things you want people to know, that they can get colon cancer screening, that they can, you know, but it doesn't stress me out too much if they're not on top of our strategic planning.
Does it stress you out that they don't know there's a quit line?
Yes.
Yeah, anybody know there's a quit line?
But people who may not smoke may not know that there's a quit line. But having said that, the getting the quit line out there, that would stress me out. And in fact, there were a lot of activities we had to try to put the quit line everywhere we possibly could. So,
I mean, I'm not faulting the state.
yeah.
It's what you just said. If you don't smoke, maybe you're not aware, which means you can't pass that message on when you need to.
Right. So if I were to say if I were to pick between which message I would want people to know, is that 1-800-QUIT-NOW, free patches and gum, you know. And so, and you probably could come up with a couple other major important messages for people to have. So, but to me, the fact that there's an organized cancer planning process.
How about in this room, the fact that most people didn't have, is that cause you alarm, given that we should be stakeholders and be part of the process? No, not really.
You know, I would say might wish the number would be a little higher, you know, but we, you know, I think it's interesting. I mean, how many people have been in a position to make recommendations to people who quit smoking recently? That's something that comes up a lot. Yeah. So I mean, no, just yeah. Well, I mean,
Yesterday.
okay. So that's good. Yeah. But I mean, I think our generally, you know, I think if you start paying attention, there are a fair amount of advertising about that. And if I were to say, well, how effective is our campaign? The primary audience would be people who are smoking, you know, or people who are living with people who are smoking, you know, and we would look at that. I mean, we had major concerns about how many people were calling the quit line at a certain point, and we put a lot of different efforts into promoting it. But I wouldn't be saying let's make sure all the people who aren't smoking and really don't know anyone who's smoking, you know, that would be a secondary audience for me. So, you know, having said that, I think there's probably quite a bit further we could go in promoting a quit line.
That was making my business. I hear someone say, oh yeah, I'm trying to quit, it's hard. I would say, oh, do you know about the quit line?
Yeah.
And then have a whole conversation about it.
I agree. Although I think, you know, what we want are for people to call, you know, and we want people to be able to access services and then ultimately quit. And I think the ability to put that, like, you know, we recently had a meeting in East Baltimore where a community group decided to put that everywhere, that they, you know, all over their walls, in everything. I think at one point we put it up in every possible state building we could. You know, so you do everything you can. Unfortunately, there's not you know, when CDC did have money for promoting the quit line, we saw a huge increase in the number of people calling. So it was like a controlled experiment, you know, not randomized exactly, but, you know, it was like baseline number of calls, then CDC put out a whole lot of money for, you know, and it was targeted advertising that talked about the advantage of the quit line, and we saw tripling, quadrupling of the number of calls, and then it slowly tailed off again. So, I mean, that's something that you could build into a plan. But I probably wouldn't be as focused on this population.
Thank you, audience, for coming today. For those of you who attend regularly, you know there's pizza in the gallery. You turn left and then right, immediately following. Make sure you pick up a ticket. I saw Nicole over on this side, so if you don't have a ticket, go out that exit and she'll give you one which entitles you to pizza. Special thanks to Ashlyn and Yati, for helping with the microphones today. And Elizabeth Platts and I are open to having you get more involved in either the collaborative or looking into Maryland's cancer issues. So we thank Meredith today for coming.